Thank you very much. I think this is my third opportunity to speak at the SLC 6A 1 Symposium, and I would like to thank Amber for the opportunity to do it these 3 times. It's been just a wonderful opportunity for me to be part of this community. I very much enjoyed the monthly symposia that we have, albeit a little bit early in the morning in California time, Amber. In the past, I've spoken about pharmacological strategies for the treatment of SLC 6A1, but this time I'm going to do something a little bit different. I'm going to talk about some of the therapies that are in the pipeline for the treatment of epilepsy, both small molecule and also what I'll refer to as biological therapies. And the reason I'm doing this is to give the researchers in our community a bit of motivation to show you what other disease areas in epilepsy are doing, and to give you perhaps models and ideas on how you might apply these concepts to SLC 6A1. But also for the patients, families, and the advocates in the group to give you a sense of where we could all be going in the very near future. So the title of my presentation is Seizing the Future, Promising New Treatments for Epilepsy in Clinical Testing. Now, I didn't write that title. It was written by the artificial intelligence Bard. It's much better than I could have come up with, but it's the only thing in my presentation today that was not written by me and was written by an AI. So on the slide, you see a schematic illustration of the history of anti-seizure medications, starting about 163 years ago with the introduction of bromide. And over this 163-year history, we have made available to patients upwards of about 30 different molecules for the treatment of epilepsy. And this legacy of anti-seizure medications is the result of testing in animal seizure models and not in specific epilepsy-related diseases. None of the animals that were used to identify any of these 30 drugs actually had epilepsy. They simply were a normal animal that had been induced to have a seizure. And this turns out to be a very effective way of identifying molecules that can be used to treat seizures. The drugs that are developed through this mechanism are generally broadly active in epilepsy. The approach has provided more neurologic therapeutics than perhaps in any other disease area in neurology. But in the last few years, largely as a result of the genetics, we've seen a dramatic change in how we're thinking about creating new medications for the treatment of epilepsy. And that's what I'm calling the emerging strategy here. We're beginning to think about ways of targeting epilepsy mechanisms. The idea is to address the underlying pathophysiology of the disease. Sometimes this is called a precision medicine approach. And at the moment, I think it's fair to say that we only have one medicine that was conceived in this fashion, and that is the mTOR inhibitor everolimus for the treatment of seizures associated with tuberous sclerosis, which is a mTORopathy, a disease that's a dysfunction of the mTOR signaling pathway. But in the next SLC 6A1 Symposium, I'm expecting that I'll be able to enhance this slide with additional mechanism-based therapies that are in the pipeline. And I'm going to tell you now in the remainder of my talk about several of these that are in advanced testing and are likely to be available to patients very soon. So as I mentioned, it's the genetics that is driving this. And this slide illustrates the more common genetic etiologies of epilepsy for the monogenic epilepsies. The sodium channel gene SCN1A is at the top of the list. There are many variations in this gene that are known to be associated with rare forms of epilepsy. The KCNQ2 potassium channel gene, which I'll be talking about first, is also known to be an important epilepsy gene. And you can see SLC6A1 is on the list there. It doesn't have, at the moment, the largest numbers of variations. So this all began in near the turn of the last century, 1998. It seems so long ago, when Mark Leppert at the University of Utah identified the first gene for an idiopathic generalized epilepsy using the old-fashioned technique of linkage analysis in a pedigree of patients from Canada. And he sequenced this gene, and it turned out to have homology with a potassium channel in the heart. And so he proposed that this was a potassium channel gene, and it turned out to be a potassium channel gene. And it encoded a potassium channel that underlied an ionic current called the M current that had been described in bullfrog sympathetic ganglia and also is present in the brain in neurons. And this potassium channel is different from the potassium channel that you might have studied in basic first-year physiology class that's responsible for the repolarization of voltage-dependent action potentials, the so-called delayed rectifier, in that the M-current potassium channel turns on very slowly, and it's also low threshold, so it turns on at hyperpolarized potentials, hyperpolarized to the threshold for action potential generation. And as a result of these characteristics, the M current is responsible for regulating the generation of action potentials near threshold and preventing a neuron from transitioning into an epileptic firing pattern. So if you block this particular potassium channel, you can generate seizure activity, and if you can enhance the activity with an opener of this channel, you can have an anti-seizure effect. The old anti-seizure drug ezogabine was found to have this activity of opening the M current, or what we refer to now as the Kv7 potassium channels. And there's a new molecule currently in the pipeline of development called XEN1101, which has much more potent activity than ezogabine as an opener of this particular potassium channel. And in animal models shows a broad spectrum anti-seizure activity with a very good profile in the sense that there's a wide separation between the ability of this drug to block seizures and the toxic effect of the drug in terms of an effect on the rotarod. So this molecule is now in clinical development, and you can see this is a schematic illustration of the clinical trial design that has been used. Patients with focal onset seizures So these are a broad group of patients without a known genetic etiology. These patients were randomized to receive either placebo or different doses of XEN1101, either 10, 20, or 25 milligrams. And then after they finished this blinded period of the study, they were all allowed to use a 20 milligram dose of XEN1101 in what's referred to as the open label extension. And this is the result of the study that we recently published last month in the journal JAMA Neurology, showing that there was a very nice dose-dependent reduction in median seizure frequency as the dose of XEN1101 was increased from 10 to 20 to 25 milligrams. And similarly, the responder rate, which is the number of patients that achieved a 50% reduction in seizure frequency, also showed a nice dose-dependent relationship there. So this study was widely heralded as demonstrating that Xenon 1101 and its underlying mechanism, opening of the Kv7 voltage-activated potassium channel, could be a potentially important strategy for the treatment of epilepsy. Here's the results of the open label extension, where patients who were on the placebo had a very small decrease in seizure frequency, just the placebo effect. And when they were switched over to the 20 milligram dose of Xenon 1101, you can see that they quickly achieved the seizure frequency reduction that the patients in the blinded phase of the study had achieved. Now, these data are hot off the presses. They were just reported to the public on Monday of this week. And it's a study with this drug, XEN1101, in major depressive disorder. And what you can see is that there's a dose-dependent and statistically significant reduction in the depression scores of patients with major depression. These are not epilepsy patients. They have severe depression. And when they received this drug, they had an improvement in their depressed symptoms. So why am I showing you this? Well, we all know that depression is an important comorbidity of epilepsy. And we now have, for the first time, an opportunity to perhaps treat both of these symptoms that often occur in our patients with epilepsy. So I think this is a very exciting new development, and we'll see where it goes. So up until now, I've been talking about testing a drug in a patient population that perhaps has many different etiologies and is only characterized by the fact that they have focal onset seizures. How can we apply this to precision therapy to treat patients who we understand their underlying genetic basis? Well, there's been an explosion of activity around this in recent years, and we can think about the XEN1101 data as an opportunity to perhaps examine whether this molecule might be useful in epilepsy that's specifically due to defects in the Kv7 potassium channel. So we have two forms of epilepsy that occur when you have mutations in this particular potassium channel. You could have benign familial or benign infantile convulsions, or you may have a severe developmental and epileptic encephalopathy. And I think it'll be interesting to see whether this drug can have unique activity in the treatment of this developmental and epileptic encephalopathy. You can see that there's two different molecules now that are being advanced with this mechanism. I'm going to talk a bit about the voltage-activated sodium channel as a particular target. As I mentioned, the SCN1A voltage-activated sodium channel is the best recognized epilepsy gene and is believed to be the predominant cause of Dravet syndrome. We have molecules that either can upregulate this sodium channel when its expression is defective, or to reduce its excitability in situations where you have a gain of function causing the epilepsy. And this occurs in various forms of epilepsy. I'll just very briefly mention that there are now targeted GABA A receptor subtype selective modulators. You see a number of those on the slide here. There are groups investigating selective serotonin agonists based on the fact that fenfluramine, a serotonin-releasing drug and a direct-acting 5-HT2C or serotonin 2C receptor agonist, is useful in the treatment of Dravet and Lennox-Gastaut syndrome. That has stimulated an interest in the opportunity to use more selective drugs than fenfluramine. And finally, there's work being done with a selective NMDA receptor modulator as a potential treatment for an epilepsy that's due to gain of function in the NMDA receptor. So let's talk for just a second about voltage-activated sodium channels. As you know, the sodium channel is the basis for the upstroke of the sodium-dependent spike or action potential. The sodium channel can exist in 3 different states: a rest state, an open state, and an inactivated state. Under normal conditions, sodium channels mainly cycle through the open state very quickly, and then they inactivate and they're no longer activated. So the sodium spike is very, very brief. It's less than a millisecond. But there is a small amount of current that is passing through the voltage-activated sodium channel under conditions when there is no sodium spike, after the sodium spike is over. And in certain mutations of the sodium channels, you get a greater amount of this, what's referred to as persistent sodium current. And this persistent sodium current can be very epileptogenic because it causes depolarization of the neuron, bringing the neuron closer to the activation threshold for sodium spikes and resulting in abnormal excitability, hyperexcitability, trains of action potentials. This is a slide that shows this persistent sodium current, that the sodium channel's not adequately closing. And we now have a drug that's in development that can selectively block this persistent sodium current. And it'll be interesting to see how it how patients with gain-of-function sodium channel mutations respond to this medication. This medication is much more selective for the persistent sodium current than are the conventional sodium channel blockers that we use in everyday practice of the treatment of epilepsy, such as carbamazepine. A major advance in pharmacology was made with the development of this molecule called NBI 921352. All of the sodium channel blockers that are currently used, and including this compound that I mentioned, blocks the persistent sodium current, are non-selective. They block all of the various types of sodium channels that are in the brain, and also those that are in the heart and in the muscle. But recently it's been discovered that you can generate small molecules that can selectively block just a specific brain isoform of the sodium channel called the NAV 1.6 sodium channel, which is encoded by the SCN1A SCN8A gene. This molecule was tested in focal onset seizures, and it was not effective. And so it's been dropped for treatment of focal onset seizures, maybe because in those patients which didn't have any specific mutation in this gene, there were other sodium channels that were involved in the epilepsy. But of course, the question now is, what about in those patients that have a gain of function specifically in the SCN8A gene? This particular molecule could be very good for that purpose as a targeted treatment. So this could be one of the new precision medicine treatments of the future. And I'll just take a couple of minutes then to end with a discussion of what I refer to as biological therapy. So these are oligonucleotides. We're moving now from small molecules to actually gene-based therapies. And we have the oligonucleotide therapies, and we also have viral vectors that you'll be hearing about later from Dr. Gray. So this is the most advanced oligonucleotide therapy that's in development for epilepsy. It's being developed by a company called Stoke Therapeutics. The name is STK001 antisense oligonucleotide. And it's an oligonucleotide that causes alterations in splicing and results in a reduction in what's referred to as nonsense-mediated degradation of the messenger RNA for the SCN1A sodium channel. So in Dravet syndrome, we have a haploinsufficiency of these channels, and we want to upregulate the surface expression of the channel, and we can do it with this rather creative antisense oligonucleotide approach. It's been shown in animal models to increase the mRNA expression as well as the actual expression of the sodium channel protein itself. It also improves survival in a mouse model that has Dravet syndrome due to a mutation in the SCN1A voltage-activated sodium channel. So this is the latest data hot off the presses from a study in which this antisense was administered to children with Dravet syndrome. Now, unfortunately, the oligonucleotide can't be given in a pill, so it's administered as an intrathecal injection. But this can actually become fairly routine, and it's tolerated for many other neurologic diseases. And in this case, the patients received 3 of these intrathecal injections at intervals of a month or 2. And you can see in the graph below that there wasn't an immediate effect as in a reduction in seizure frequency in these patients with Dravet syndrome. But over time, there was a progressive reduction in the number of seizures such that by the end of the study, the patients who received the highest dose had very few seizures. So this was really, I think, a very dramatic demonstration of the first gene-based therapy in an epilepsy. And we're very much hoping that the good news here is going to continue. And this will certainly revolutionize the treatment of Dravet syndrome, not only necessarily from the point of view of a reduction in seizures, which of course is very, very important, but we're targeting the underlying mechanism of the disease. And so there's the possibility that this kind of a therapy could benefit the comorbidities of the disease, such as the behavioral problems and the intellectual problems and so forth. That's really not possible with the anti-seizure drugs that just work on the anti-seizure mechanisms. But when you have a drug that can modify the underlying neurobiology of the disease and have a disease-modifying effect, you can affect not only the seizures, which are being studied here because they're easy to quantify and measure, but some of these other softer and more difficult symptoms of the disease could also be effective. And then finally, I'll end with data that's also very, very much hot off the presses. This is an antisense that basically knocks down the SCN2A gene. So this is another voltage-activated sodium channel. I should mention that the SCN1A gene is typically expressed in interneurons. This particular sodium channel is in excitatory neurons. And when there's a gain of function in this sodium channel, in other words, it operates too robustly, it can lead to hyperexcitability and seizure generation. And these patients that I'm going to be talking about now have a gain of function in this gene, which causes a very severe form of epilepsy. It's called SCN2A, developmental epileptic encephalopathy. These patients have seizures immediately after birth, and they often have status epilepticus, so they have seizures that continue and don't stop. And so this is a very significant risk for early mortality and SUDEP. It's really a tragic condition. This company was developing this antisense that knocked down the activity of this particular gene, and they got a call from a medical team that said, we're run out of options for this patient. He's a newborn with severe status epilepticus that's not refractory to any of the drugs we're using. And they provided the antisense and found that after the first intrathecal dose, the status epilepticus slowed down. And then by the 7th dose, there was no status epilepticus anymore. And the patient is doing very well. You can see breastfeeding clinically stable on this antisense approach. Now, this was just one patient treated on an emergency use basis. So this stimulated the company to try this in other patients. And so far, they've looked at 4 patients, and you can see that in all cases there's been a dramatic reduction in seizures. So again, this is very tantalizing data that is giving us hope that another biological approach can be useful in the treatment of epilepsy. For me, this is just absolutely remarkable. I never imagined that I'd be standing up here telling you about these kinds of therapies. We've really never had anything like this in the field of epilepsy. And I think it really bodes well for a bright future of therapeutics in the field of epilepsy. So with that, I'll end and be happy to answer questions when we have our panel session. Thanks so much for your attention.